Yep, I've started it, yeah.
You've started. Okay, so good afternoon, everybody, and welcome to the Suffolk and North East Essex Integrated Care Board, our second meeting. This is a very focused meeting. There's only two substantive items on the agenda seeking your approval today. So we're hoping to be very expeditious in the way we deal with these matters, and our target is to finish at 3 o'clock. So first of all, questions from the public. Joe, can I come to you? Are there any questions which have been raised in advance prior to the meeting?
No, I haven't received any.
Okay, thank you very much. And then apologies. Again, I'm going to come to you, Joe, if I may, for apologies, attendees and observers.
Right, apologies received are from Andrew Kelso, Tanya Curry, Frida Barty, Nick Hume, Neil Maloney is here deputising for him, Amanda Lies, Laura Taylor-Green, Ed Creasy, who's an observer, Andy Yakub, and Councillor Bird.
Okay, lovely. And let's hope we've captured anybody.
Sorry, that was Councillor Reid. I wrote that down wrong.
Councillor
Sorry.
Reid. Yeah. Okay, thank you very much. Let's then move on to the next agenda item, which is declarations of interest. So are there any declarations of interest or potential conflict of interest with any agenda item other than those of which we're aware? And no hands raised, so we're going to say no declarations of interest, thank you. And then the next item, which is minutes. Now we've got a little bunch of minutes in two parts. First of all, for us to receive the three CCGs minutes of their last meetings on the 25th of June, when they met in common, but you've got three sets of meetings there. We are to receive them. I'm just going to ask the question, they're not for us to approve, because of course that was CCG as opposed to the ICB, but we're receiving them so that they stay in the public domain. Are there any questions or points about them that anybody would like to raise? And again, I see no hands raised, so we'll simply say received and noted by the board. Thank you very much. And then our inaugural meeting, for those of you who are there in Newmarket on the 1st of July, you have a set of minutes there which are for your approval, if you're so minded. I'm going to have a go at taking them on block rather than turning the pages. First of all, for accuracy, are there any issues of accuracy that anybody would like to raise? And again, I see no hands raised. So shall we say that the board received the minutes of the 1st of July 2022 and resolved that they were a true and accurate record of that meeting? All agreed? And no objections, so we'll take that as approved. Thank you very much. And then matters arising. You've got a very short matters arising paper there, two items, one of which is not due. September is due in September when we next meet, and one of which is recorded as complete. Is everybody content that the matters arising record as presented is accurate? Nobody saying no. Okay, so we'll resolve that it's accurate. And then are there any matters arising from the 1st of July 2022 which you think should have been in the action log and which the action log hasn't captured? And again, no hands raised, so we're going to say that it's also complete. Thank you very much, everybody. That's great. Those are our formal process issues, in which case I'm going to move on to the next item, which is the general update from Ed. So Ed, all yours.
Thank you, Chair. So just wanted to firstly recognise how hard everyone is working in the health and care system at a really stressful time, but I'm very pleased to report that we met our commitment as a system at the end of June to deliver on the 104-week waits, which was a huge system effort. So very grateful there, but we now move on to 78 weeks cohort, as well as looking at cancer and trying to improve urgent care and primary care access and the whole list of issues. But certainly can see very clearly how hard everyone is working. So a big thank you from me. I've got 6 points I wanted just to update the board on, some relating to Essex, some relating to Suffolk, and some in common. So to start with, we'll go to Essex, North East Essex. So very pleased to report that North East Essex in the national diabetes audit has come top in England in the audit, which was organised by NHS Digital and Diabetes UK. Top for the number of personalised care plans delivered, 64% against a 27% national average. Top for diabetes foot checks, 81% against a 51% national average. And top for educational events, 65% against a 37% average. This is a nice system story because the diabetes service is provided by the Suffolk GP Federation. So very nice Suffolk and Essex collaboration, but very delighted with those audit results. Secondly, the SOS bus that has worked in Harwich and in Clacton was nominated for the NHS Parliamentary Award under the Health Inequalities category by Giles Watling MP. There were 700 nominations, and the service itself is a very excellent multi-agency service provided by Open Road, EPUT, Tendring District Council and others. And I'm very pleased to say that they won the National Award for Health Inequalities. So two brilliant successes in North East Essex. The National GP Survey has been published, Patient Satisfaction Survey. We came the top ICS in the East of England, which we're very proud of, with a 77% overall satisfaction rate against a 72% national average. And I've written personally to all the practices to thank them. But if you look at previous surveys, that's a fall from where we are. So whilst we're performing relatively well, I'd say that patient satisfaction has fallen from where it was even last year. So it's kind of important to have that context. In Suffolk, the Sizewell C has received government approval in terms of the planning. So that now moves forward, and there's a lot of work, multi-agency work to prepare for that in terms of the additional population that we'll have on the Suffolk coast, and to think about the services we'll need to enhance and to support that. I think there'll be about a 10,000 workforce as part of that. So that'll have its implications for our services that we commission. The fifth thing is around dentistry. So a couple of important developments we've made as an ICB, even prior to taking on our delegation in a year's time. We've worked with NHS England to launch a procurement for 3 dental access centres, which will conclude by the end of August. This is for a centre in Bury St Edmunds, Ipswich and in Colchester, which are our 3 main population centres, and will be serving 550 patients a week with urgent dental care. So we're very, very excited about that procurement, and we hope we have a good response to it. And secondly, we've worked with the University of Suffolk to launch a social enterprise, which will both provide dental services starting at the university site in Ipswich, but also act as a centre for dental development for the future, which I think will help to attract dentists into the social enterprise. So we've got a model we're really very, very pleased with, and we'll brief the board more fully in the future. And then finally, just to say, we've been through a recruitment process for our Director of Finance for the board. We are in the process of finalising that, and we'll be making an announcement very soon. And then finally, we also had a recruitment process for our voluntary sector assembly chair. That wasn't a successful process, and so we'll be relaunching it very soon with Susanna's help. So just some updates from me. Well, thank you.
Thank you, Ed. That's really very helpful, and some great news there, and well done. Congratulations to all those who have been party, well, to the whole team that's party to creating that good news. Of course, you also flagged some challenges in so doing, Ed, don't you? And I know that the board will be very keen to know that those challenges are on your radar. Any questions for Ed on that very brief update? And Nick and then Steve. So Nick first.
Thank you, Chair. Really, Ed, I think that's brilliant. That's a lovely update. I just wondered, specifically with point 1, with the Federation running North East Essex Diabetes Service, which I've been aware of for a little while with my board position on the Fed. I just wondered whether we were going to try and share that learning across Suffolk, so that we can have an ICS wide being best in the country rather than just an element of our place.
Yeah, no, I've asked that that obvious question of the team, and I'd like an independent review of that, because it would, looking at it logically, would make a lot of sense, wouldn't it? But I know there's also excellent work in Suffolk too, so just want to work that through. But I think that would be a good action, maybe, Joe, to register, and we can, with Richard's support, bring that to a conclusion. But obviously, if we've got one service that's delivering the best in the country in terms of the audit, then we would want the same across our system, wouldn't we?
Yeah, and Nick and Ed, would you both be happy if that was the subject of an update at the next board meeting? Would that be helpful?
If that was appropriate, yeah.
Yeah, absolutely. Wonderful. Thank you very much. And Steve?
I was going to make the obvious point as well, Ed, about spreading the good practice from North East Essex. It's great that we've got that. And I was also going to ask about the dentistry initiatives you referred to, which are all great. It's good to see we've got sort of access widespread, as well as the possibility of the link up to education and future development that you referred to in the university, which, you know, I'm involved with in another place, so I'm really pleased about that. I'm just wondering about access and any plans we've got to perhaps approach access differently from this classic, those who know how to run the system get in, and those who don't have to find their way around. It's the inequalities thing, really, isn't it? So have we got any means of making sure those really good centres in 3 important places are kind of accessed appropriately, proportionately by our various populations?
I mean, that's a good question, Steve. We've put it in the obvious population centres where there is the obvious deprivation, but whether the population itself will access it is a different question. So I think let's take that as an action. Richard may, being closer to it than me, may have a view from the task force, whether that's been a conversation thought through. But definitely we need to keep hold of that challenge, Steve. That's a good one.
Did you want to come in and say anything on that, Richard, or is that too early? Is that something you want to think about first?
Too early. We have had 3 meetings in the task force now, so I'm happy to pick that up with Greg, who's leading on it with us in terms of that.
Okay, so we'll take that forward. Good point, Steve. Thank you, and love the focus on the inequalities point as well. Very, very much, absolutely on the money there. So thank you. Any other questions, colleagues? And I don't see any other hands raised. So Ed, thank you very much for that update, and we look forward to the next. In which case, let's move on then to item 7, which is the finance section. So the first of our substantive reports today to consider and, if possible, approve the ICB financial plan and budgets 22-23. And Chris, I'm going over to you.
Thanks, Will. So the paper is brought here to ensure that there's a formal approval of the financial plan and budget by the board. So just in terms of background, the NHS had a highly protracted planning round this year due to a number of issues outlined within the paper. And obviously further complicated by the transition from clinical commissioning groups to integrated care board. During the planning round, the clinical commissioning groups approved the financial plans and budgets. However, their ability to approve that on behalf of the ICB wasn't made clear by NHS England, hence the need to bring the paper here to ensure that we've got that kind of a formal approval process within the organisation. So the paper summarises the key financial duties of the ICB, both individually and collectively with partner organisations which make up the system control total. So that would be the East of England Ambulance Trust, ESNEFT and West Suffolk. There's a summary of the system financial plan which meets those key financial duties. However, to note, there is still risk contained within that plan in relation to further inflationary increases and further waves of COVID, which aren't contained within the current funding settlement. So that's consistent across the whole of the NHS and not just something unique to ourselves. The paper contains a summary of the overall plan for the ICB, which also meets those key financial duties and associated budgets by directorates, and notably the budgets to be delegated to the Alliance Committee in line with their scheme of reservation and delegation. So for primary care, mental health, and further services within there. So the ask of the board is twofold, really. One is to note the overall system financial plan and the key financial duties, and in terms of approval, to approve the ICB financial plan, the budgets by directorate, and the budgets to be delegated to the Alliance committees. So happy to take any questions.
Chris, that's great. Thank you very much. And we have a hand raised from Steve, so I'll go straight to you, Steve.
Thank you.
Yeah.
Yeah, Steve Feast, one of the non-executive members.
Yeah.
The recent pay awards, what impact is that going to have on our planning? Has that been factored into this, or is that something we need to revisit in a number of months' time?
So in terms of the new pay award, so nationally there was further reserves held back by NHS England to take the pay award up to 3%. So there's 2% within our current funding envelope. NHS England will be issuing further resource out to systems in order to meet the cost of the pay award. It's not a perfect formula, so it will be impact on different organisations in different ways, but that hasn't been funded by Treasury. So in order to do that, NHS England and the Department of Health and Social Care have had to find that from existing resources, and that will mean that some further developments will be cut or slowed down within the health system. So we'll waiting to see the full impact of that, but the indication will be for further developments in technology and potentially for diagnostics as well. Like I say, because there's been no funding allocated by Treasury for that. So we will receive in coming months further allocations and resources to pass through to NHS providers for the impact of that pay award.
Okay, so we'll be updated later on in the year once we know more about the sound of it. Second thing is in the ICB corporate budgets, we now have a medical director as well, which isn't reflected on that panel. Not for wider discussion now, but I think, unless I've missed something, that looks to me like something that needs to be factored in on page 5 of 6 of the report.
Yeah, so the budgets contained are by directorate. I think there's ongoing discussions about the portfolio of each of the directors. So as and when those get widened, budgets will be moved between the directorates through the formal environment process. So like I say, as it's a new post at the point of setting the budget, we need fuller clarity about the portfolios and associated budgets. Like I say, so that will change as we go forwards.
Okay, so again, we'll hear more in due course. Sorry.
Yeah, sorry, Steve. And just for clarity on that, for Steve, Chris, though, where Steve might be coming from, whilst you might via between budgets, Steve, I don't want to put words into your mouth, but were you basically going to say that you didn't want you would assume the bottom line wouldn't change?
that would be the better outcome, absolutely.
Yeah.
But given the much discussed quality and safety risks that running hot in the NHS at the moment is causing, I just want to make sure that we are going to be adequately resourcing within that overall budget envelope the new medical director post, as well as alongside Lisa's role as director of nursing quality.
Yep. So the corporate posts are all, the funding is contained within the budget. Within there, it just currently sits within the chief executive office at this point in time.
Okay, thank you.
Yep.
Okay, thank you, Steve. Thanks for that clarification, Chris. Let me go to Nick and then I'll go to Maddie. So Nick, all yours.
Thanks, Chair. Really, Chris, it was just to pick up on something you just said about some money may be made available by Department of Health for NHS providers. I just wondered on behalf of primary care whether that was likely to be inclusive of primary care, which sits as an independent contractor currently.
So from what we understand, the pay settlement as it flows through would only cover primary care from core services and not from delegated as of this point in time, but we're still waiting for the detailed guidance. In the same way as other previous agenda for change uplifts would have been applied. Like I say, we have sought clarity on that issue. We're waiting for the detailed guidance to come through.
Okay, so that guidance to a future board meeting, Chris?
Yep.
Yeah, wonderful. Thanks. Thank you, Nick, for that. And then Maddie.
Thank you, Chair. So it's just a couple of questions of clarification. Chris, there are obviously in table 4.3 2 lines that relate to primary care, and just for clarity, that one relates to medicines management and locally contracted services, and the other relates to nationally delegated services in the national contract. Just wondered if that would be helpful to clarify for the board. And the second is just in table 5.1, the variation between the different alliances, that relates essentially to differences in the weighted population in each area.
Thanks, Maddie. Very helpful. And I saw you nodding, Chris. Did you want to add to that at all?
No, they're just helpful points of clarity from Maddie.
Very helpful. Yeah, thank you, Maddie. Okay, so no further questions that I can see, no further hands raised. So we're asked as a board to note the overall system financial plan and the financial duties of the ICB, which I think we can take as noted. And then we're asked to approve the financial plan for the ICB, the budgets by directorate for the ICB, and the budgets delegated to each of the alliances. Can I take it that we are approving all those in one go? Is this something that we can take nem-con? Is there anybody against any that are resolving so to approve? In which case, shall we take it that there is unanimous approval as sought? Yep. Thank you very much, everybody. Lovely. Well done. Agreed. Thank you. In which case, then, on to the next item, strategy, the Newmarket Community Diagnostic Centre. And Richard, I'm going to go straight over to you.
Thank you, Chair. So this is going to be a double act between Craig and I, of which Craig will do the lion's share of the work, which is exactly the right way round. So I'm really pleased to be bringing our first business case to the ICB, and that is one of our 3 community diagnostic centres. So we're seeking approval today, both in terms of the content of the business case and to enable us to send this on its way to NHS England as part of the national process that is underway. Just a couple of words, my background, and then, as I say, I'll hand over to Craig. So as you'll see in section 1, just for colleagues' benefit, this is part of a much bigger process that's been going on for the last couple of years, which was sparked out of the Professor Sir Mike Richards' review into diagnostics across the NHS. So effectively that review was looking at over the next 5-10 years, what's the shape of diagnostics going to be, what do we need, and how we're going to move forward, given we've got an ongoing significant demand for diagnostic services. What's come out of that as one of the planks of work is the need to develop community-based diagnostic centres, which in effect creates additional capacity, but also meets the national goals and indeed local goals of putting services closer to where patient need is, and importantly, particularly taking account of where inequalities are across the health and care system. And that's a key driver, as you'll hear, in terms of the work that's happening. Many colleagues will be aware that we've got 3 community diagnostic centres in development. The first one we approved in the previous clinical commissioning groups, which was Clacton. The second one we're bringing here today at Newmarket, and there is a third one in development around Ipswich that is earlier in its process, but we will hope to bring through in the not too distant future the conversation. The reason that we're bringing it within this time frame is that we need to get it into NHS England by the end of July in terms of this next funding round. So there's a bit of time pressure really upon us to do that. But Craig will be able to provide all the detail in terms of what the actual proposal is now and how we've approached it. Thank you.
Thanks, Richard, and good afternoon, everybody. So I'm not proposing to go through the whole case in huge detail. And I know a number of you have had a chance to have conversations about this, and hopefully those comments have been fed into the case. But we had a really useful meeting with Steve and Tanya at the end of last week. And we haven't had a chance to incorporate their comments yet into the case, but we intend to. So if I can just go through, I don't think it changes anything fundamental about the case, but hopefully, and Steve expressed this well, hopefully it will help us get through the approval process more smoothly than we otherwise would do. So we intend to include a section that relates to our organisational strategy, and I think this is broadly consistent across the ICS, that it's very clear that what we want to do is, as far as possible, do as little acute work on the main acute site as we possibly can. So a strategy to move both acute community services out of the centre in Bury St Edmunds and into local hubs. We've got some very successful examples of that in Mildenhall and Brandon. We have the intention to build Newmarket into a health hub, as well as create a further one in Haverhill and indeed at Western Way in Bury St Edmunds. So the strategy is to get as much out of the centre as possible. As part of that, we intend to use our population health management data to inform decisions and better target treatment. So, as I said, we're already doing that in Brandon and Mildenhall, where the multidisciplinary teams are coming together, using the data that we are providing, and then targeting interventions in order to prevent exacerbations and the further need for specialist care. So we will put something into the case to talk about that and to describe how we intend to use that in Newmarket. And also we've got a team working on some words around how we will better use artificial intelligence, particularly in terms of reporting. So it won't necessarily impact on the volume of work that we do, but it will hopefully improve the efficiency with which we report some of those scans. The health inequalities that was mentioned earlier, the strategy of the organisation in moving services out is explicitly designed to seek to address health inequalities where travel and the cost of travel is a barrier to access. We know that where we put services proximate to areas of deprivation, that we can increase access to healthcare. Newmarket and Red Lodge, which would be able to access the facility, has some pockets of deprivation, and therefore boosting the services at Newmarket will help in that endeavour. for information, likewise, that the next health hub that I think we as an ICS would seek to develop would be in Haverhill, where we've also got significant bits of deprivation. The biggest risk inherent in the case is workforce. It is the challenge that we are all dealing with at the moment. And the first obvious question when we seek to increase capacity, to increase physical capacity, is how are you going to staff it? There are some innovations in workforce, particularly around the establishment or the increase in the use of assistant practitioners and consultant radiographers, and we would seek to expand on that. We have seen, and it's true in other areas, and I think it was true in Clacton, that opening a new facility, any new facility is attractive to staff, and therefore you do get a bit of a honeymoon period. The danger is that we're taking staff from elsewhere across the ICS. So workforce is very clearly noted on the risk register and would be our most significant risk. And I think Steve's final comment was around maybe doing a little less of the history and a bit more of the strategy. So we will amend the comments in the introduction accordingly. My final more general comment is to thank colleagues at ESNEFT. So Shane Gordon and his team were instrumental in the preparation of this business case, and learning from some of the lessons involved in the preparation of the successful preparation of the case for the Clacton CDC. We could not have produced this in the timescale we have without the help from colleagues across the ICS. I know that we've learned a lot from them. I think they've even learned a little bit from us, but it has been a really productive relationship. So a genuine thanks to colleagues from ESNEFT in preparing this. So, well, I'm very happy to try and answer any questions. Just please don't make them too detailed.
Okay, great. Thank you very, very much. And Richard, did you want to add anything before I go to questions?
No, that's fine. Thank you.
Okay. In which case, I'll go to Nick, then Neil, Lisa, then Steve Clark. So, Nick.
Thank you, Chair. You just said don't go into too much detail, Craig, so this may need to fall outside this meeting. As a GP, just to give context, who works in Newmarket Hospital in my new build practice within the grounds that this clinical diagnostic centre is planned to be built, I was a little bit surprised that it was the first I'd heard of it 2 days before the board, but that's by the by. I'm very much supportive that I think community diagnostic hubs are the way forwards, and I'm fully behind the idea of getting my population with my Oakfield hat on a better diagnostic centre closer to home. I think that's definitely the right thing to do. There are two particular elements which I say may be too detailed for this meeting that I wanted to query about. One which was a type of lung function test with reversibility, which is currently something that the ICS and the entire country are seriously struggling with in primary care to get diagnoses of asthma and COPD. But for some reason that's been excluded from this diagnostic centre, but is at the Clacton one. So I wondered if maybe that could be added in, but outside this meeting. And secondly, in terms of early diagnostics of cancer, some of the most important ones that I see as a GP in terms of picking things up are endoscopies and colonoscopies. And once again, they are also not included in the scope of this plan, but are in Clacton. So I just had a couple of questions about that. My third point was about phlebotomy. And I just wondered if the numbers weren't quite right, because it looked like there were 9.8 whole-time equivalent phlebotomists to do 5,000 bloods, which is only 96 blood tests a week, which looks like not very many for 10 whole-time people to be doing versus my half an HCA that did 4,000 last year. So I don't know where that might need looking at.
So
thanks, Nick. We'll
over to you, Craig. Yeah.
We'll have a look at that. So I apologise, Nick, if you weren't talked to about this. I had been assured that James Heathcote had come to see you to talk about it, but I will follow that up afterwards. So the endoscopy services have been reserved for the larger CDCs. So there was a reasonably restrictive range of services that go into CDCs. If you could send me an email with whatever the spelling was of the first diagnostic test that you referred to, that would help me. And we will definitely look at the phlebotomy figures, and I'll go back and check that. So thank you.
And Nick, are you happy if that's a dialogue that you and Craig take outside the meeting, matters of detail? Yeah, okay, I see you nodding. Thanks for that. Thank you, Craig. Let me then go to Neil.
Thank you, Will. And so I'd just like to offer my support to this case. I mean, I think the whole ethos of trying to deliver local services to patients and addressing health inequalities within those local areas, I think, is absolutely essential. But look, this also delivers additional capacity, and we know one of the biggest challenges that we have is in getting access to diagnostics and reducing the waiting time for access to cancer diagnostics is just one example. So this is certainly something that has my support. Perhaps just one question, Craig, was around, you highlighted the number, in the case, there's a number of risks in there. What I wasn't sure is whether the mitigations that were highlighted in there were sufficient to reduce that. So in effect, what you were saying is the biggest residual risk was that around workforce, which I'd certainly echo your views and challenges around the ability to recruit into those posts is going to be a challenge.
I think that's exactly it, Neil, that I think all of the financial and the planning risks are all resolvable. It wouldn't be credible, I think, for any of us to say we've got workforce sorted. So given where we're starting from at the moment, it is a challenge that we are fully aware of, and we will seek to address through the commissioning process, but it is going to be tricky. I think looking at diversity in roles is one of the ways that we can all seek to address the workforce challenges at the moment. But there are ICS specific groups looking at workforce because it is such a significant issue. So it would be remiss of anyone to put in a business case and not highlight that.
And definitely workforce is a work in progress for us all, and probably will be for as long as we can see going forward, won't it? So but Neil, just let me be clear, you're not arguing that that's a reason not to do it, but it's a reason for more work in mitigation. I don't want to put words in your mouth.
It was just to highlight the fact that within the business case there are a number of risks that have been highlighted, and receiving notification that actually the vast majority of those are mitigated with the exception of workforce. And I concur with Craig. Our desire to continue to work together on that to address that within the ICS, I think, will be important.
Okay, lovely. Thank you very much. I'm going to go to Lisa and then Steve Clark. So Lisa.
Thank you. Just one question and then one point, if that's okay. Well, so the question, Craig, it says in the business case that the next stages of patient engagement. I just wondered what patient engagement or public engagement had happened yet, if any. That was my first question.
Obviously not enough, Lisa, given Nick's comment from the start. There is quite an active engagement process around the health hubs, and a lot of the initiatives that we're putting in place, have put in place in Brandon and Mildenhall, have come out of that patient engagement process. There is a real lesson in a process that involves genuinely listening and not just going and meeting people and then trying to answer their questions at the same time. So listening and taking the stuff away and then reflecting has been part of the process that we've engaged in Brandon and Mildenhall. And there are plans that are detailed in the case about the engagement process that we will embark upon over prior to it opening.
Okay.
But I think if the point is we could have done more, I would absolutely concur with that. We have been up against it in terms of the time frame, and that's something that's unfortunately slipped.
Is there an opportunity, Craig, building on Lisa's point there, is there an opportunity to do further engagement, though, working with Andy Yacoub and colleagues and others going forward?
Without a doubt. And actually, the service model builds on some of the work we've done in the Future System programme. So, and there is a comprehensive engagement process as part of that. So the two are not indivisible.
So should we take it that that's an action? Yeah, I see you nodding. And sorry, Lisa, I interrupted you there.
No, sorry, thank you. Just a second point. I think, as Richard said, it's the first business case for the ICB. I think we could make a really massive impact by getting the equality impact assessment right for this plan. So seeing it as a dynamic kind of document that we're constantly updating and using our communities to do that impact assessment, it feels a little from what I read in the EQIA, it looks like it could do with a bit more depth in it and maybe a bit more of an assessment by the groups that it seeks to assess impact on. So it would be great if it's not just seen as done, put to one side and let's get on with the rest of the business case, but is updated and constantly that impact assessed. And I think we could make a really great kind of first stand with this first business case if we do it really well.
Mm-hmm.
Great, thank you, Lisa, and thanks, Sam. That's an absolutely valid point and something that I think we all need to get better at. I'm hoping that you don't think that should preclude us submitting the bid, but as a plan to do a piece of work, I think ICS wide, if we could work on how we genuinely together address the issues of inequality in healthcare access, then we would be doing our population a service. So, thank you.
Thank you very much. And I saw Lisa nodding, Craig, in answer to your question about submission. So thank you both for that. Let me just do a little bit of management. I'm going to go to Steve Clark next, but Stuart Richardson. Stuart, I thought you did have your hand up. It's gone down. Is that because your question's been covered?
Neil asked my question for me. Thank you, Neil.
Brilliant, thanks. And then I've got Steve Feast, Richard and Sue. So let's start with Steve. So Steve Clark, over to you.
Thanks, Will. Thanks, Craig. Glad to hear you wisely identifying the rosy glow of a new premise as being a short-lived gain in terms of workforce, because you're absolutely right, that won't last. And I wonder if and this is with ignorance of the process we've got with NHS England, whether any buttons get pressed if we say a bit more about work that we are doing within our wider system to try to improve the availability of skills in our territory. Because there's quite a lot going on with our colleges, our universities, to encourage the training of local folk who stay, as opposed to imported from elsewhere. Now, if that presses buttons and makes it more likely we get approved, it's worth saying something about it, because I think we have got things there that are positives. And certainly, I know we haven't got it all taped. There's more to do, but if there's stuff around that, Craig, we could kind of strengthen the appeal of our case, because I'm assuming we're in a competitive process, is my second point. We're in the national process. There's only so many going to get through, and some of us will fall by the wayside in the national process. And if that's the case, all the more reason to play whatever cards we've got.
So I fully expect to have questions after we submit, and I'm sure one of them will be on workforce. But what we'll try and do is in the same way that we're updating some of the words to incorporate Steve Feast's comments, we'll put some more in workforce. And then I know Amanda isn't here at the moment, but Amanda is leading some ICS-wide work around workforce, and it's maybe those words that can satisfy any subsequent questions that we almost inevitably will get around workforce.
Okay, thank you very much, Craig. And now to Steve Feast. Over to you, Steve.
I just wanted to back up what Craig said right at the beginning. This felt like our new world in action. That the chief executive of a local major provider engages with us as board members on a Friday afternoon in an open and constructive way, asking how we can help the system make the bid better in order to create a health hub and an anchor institution in one of the most challenged parts of our geography, which in turn will provide employment and improve the health, early detection, diagnosis and health outcomes of a population. So I just really wanted to put on record that this feels like us in action, supporting each other to build a good business case, that if we land this is great news for the people of Newmarket. And I worked in Newmarket Hospital 40 years ago, just under 40 years ago, and I never would have dreamt that Newmarket Hospital would be described as a health hub in the future. So congratulations to all of those that have got it this far, but it just felt like this was a good process. Fellow board members, you know, this was good.
Thank you, Steve. We'll take that as a rhetorical question, I think, and gladly received by all. So thank you. And then Richard, Sue, and then Ed, and I think we'll then try and wrap up if we can. So Richard.
Just a little more context that might help the board. I think Craig's already alluded to that this goes into a process then with the national team. And I think we've said within the business case, October is when our aim would be to try and get sign off. So as you can see, there's plenty more time to keep working on this. And as Craig said, we got, can't remember, Neil, how many, but there was a lot of questions came back on the Clacton business case. So although, as Craig said, we've learned from that process through the brilliant work Shane, James and others have done, I'm sure we'll be getting a lot of the questions back that you guys are asking as well. So we've got time to keep working on it. The second thing, I'm pleasantly surprised no one's raised money so far at the first meeting. So hopefully colleagues have clocked that within the case, just to be clear from an ICB perspective, this is about new capital and new revenue. So we've specifically written, you'll see a line within there, which I'm looking at Chris because he might want to expand on, that this is the sign up is on the understanding of additionality of revenue and capital that's coming into the system. And we do need to write as an ICB organisation a letter of support for the bid, which we will do subject to obviously today's session with sign off. But Chris, I don't know, sorry to put you on the spot if you wanted to say any more on that element.
Yeah, so I think the key bits are within the tables, the additional revenue expenditure. So it goes up to about 4.4 million per year from 24-25. That's expected to be additional from NHS England, and the same with the capital expenditure. So it's over and above our existing funding envelope. And just a note in terms of the need to get this in soon is that obviously diagnostics were an area where they'd indicated they would be looking to slow down investment in order to fund the pay rise. So the earlier that we can get this in and then potentially refine as we go along, the more likely we are to be able to be in the mix in terms of that decision-making process as we move forwards. There is a question about the long-term funding, but we've made it clear in all of the documents that we have assumed that NHS England will provide additional long-term funding beyond the kind of the tables within there to the ICBs to pass forward to the trusts.
Wonderful. Thanks, Chris. That was very, very clear. Let me go to Sue and then Ed.
Thank you, Will. I wanted to say two things. If we can help at all, as you know, partners in strengthening the bid, particularly around the equality impact assessment, I agree with Lisa, there's an opportunity there, and there's probably a lot of knowledge, detailed knowledge, and also expertise that we could offer to support strengthening the equalities impact assessment around particular the ethnic minority communities in the area, and the kinds of actions that we could demonstrate that we could take that would improve accessibility. So that's one offer. And the other offer is if it would strengthen the bid in any way during the refining stage, to link it to the Suffolk skills strategy, which is part of the Suffolk growth strategy, which basically plans and specifies the workforce we need for the future and how we're training them up. If it would strengthen the bid to have a strong link to the Suffolk skills strategy, happy to make that link and make sure that we talk about the skills strategy and the kind of skills that we're training the population for.
That's great, Sue. Thank you very much. And actually, you might not have seen it, but there were a lot of supportive nods around the screen in relation to, well, both your offer, but to help, but also the skills point that you've just made. I think that's a great point, and I'm gathering, looking at Craig now. Craig, there was a lot of support around the table for that. Would you be able to do something appropriate with Sue on that?
Yeah, so I think Sue made the offer during the refining stage, and I think that's exactly where we would need to do. And it links to Steve's point about the anchor institution.
Absolutely.
Creating capacity in Newmarket, which requires a significantly skilled workforce, can only be a good thing in terms of driving economic development through an area where there is relative deprivation. So all of that links together, and we'll see what we can do in the next stage of this.
Wonderful. That's great. Let's take that as an action. So, Ed, I'm going to come to you for your points, and maybe you'd also like to have a go at wrapping on this one for us.
Well, I think most of it's been said by Steve Feast, actually. It's been a really great collaborative effort. It's incredibly exciting. The comments that I was going to make is the Clacton scheme is the flagship scheme nationally. It's got up and going quickest. It's really very impressive. So I think it would strengthen the Newmarket bid if we make it very clear this is a system scheme. SNF have been supporting West Suffolk, and we've got all of those advantages of the learning from Clacton here. So I think that would be an astute thing to do. The other one of the other really excellent things about Clacton is that they've built in a anchor institution element of creating opportunities for local people that are unemployed to build skills and to potentially get into the NHS, such as developing technicians, as an example. And I think there's quite a pipeline that's developed. And I think, to Craig's point, if we could introduce a similar scheme in the Newmarket area too, and learning from that Clacton approach, I think that would be very, very powerful, not just for the bid, but for the long-term sustainability too. So those would be my conclusion. I think this is really exciting. Well, thank you.
Thank you, Ed, and great points, great summary. So, colleagues, I'm not going to rehearse everything that everybody said. I know that Joe will have captured it perfectly, but the board has debated this this important strategic step in depth. This is my question: we've noted the access issues, the inequalities issues. Actually, the workforce is both a challenge and an opportunity, the way articulated. That there is still work to be completed, whether it's on EQIA or whether it is on further public engagement and indeed workforce development. That it still needs a little bit of refining work on strategy and so on. But with those comments and points, is the board minded to support the recommendations as made in the paper, which is to approve the business case to establish the Community Diagnostic Centre at Newmarket Hospital and support the submission of the case to NHSE for onward consideration and approval? Does anybody not wish to support? And I see no hands raised, so shall we take it that we have unanimous approval? And agreed. Thank you very much, everybody. Lovely. My personal view, then, having agreed that, what a terrific demonstration of system working. I thought that was super, and also impacting not only health but the wider determinants of health, the way that we can play this. So, and working with colleagues in our local authorities, and then undoubtedly, ultimately, voluntary sector as well. So absolutely great. Well done. Thank you very much, everybody. In which case, there is no AOB because this is a very focused agenda. It is now 4 minutes to 3. The next meeting is the 27th of September. I think we then simply go to the final item, which is questions from the public, if there are any. And I'm going to go to Simon Morgan.
Yeah, there are no questions, Will.
No questions from the public, in which case, at 4 minutes to 3, shall we close? Everybody happy? Meeting closed, everybody. Thank you very, very much. And see you all.
Thanks, everyone.
Thanks.